I'm Dr. Michael Latola.
And I'm Megan Strong.
In this week's Case of the Week, a dentist makes an excellent example for why a simultaneous crown and bridge impression technique is best.
And stem cell research heads to the lavatory, not the laboratory, urine, for a big surprise.
And if you think a tub of cream cheese is hilarious, you're going to love this week's fun-filled episode of Chairside Live. Episode 63 of Chairside Live. Megan, how are things on that side of the desk?
You know, it's going pretty well. I hobbled into the studio today because if you've been following my fitness journey here on Chairside Live, which has been kind of dormant for the past, 6 months, I just started back up again, and I did a weightlifting class on Monday, and then last night I did a yoga class, and I am feeling it, but it feels good.
Nice. Do we have any pictures from either of those sessions?
Absolutely not.
No?
No.
I'd like to make a proposal that somebody from Chairside Live follow Megan to some of these. I'd like to see. They're welcome to come to my workouts too. I just think it'd be fun to kind of little behind the scenes on you twisting like a pretzel with the other people at the yoga class. I've never been, no, I didn't mean it that way. I've never been to a yoga class, but I hear it's way harder than it sounds.
It is.
Because it sounds like it's going to be stretching.
Stretching and, soft lullaby music. No, it is hard work. And actually, one of my best friends is a hot yoga instructor, which is just whole different animal.
Oh, she does. She teaches the hot yoga.
Jokes all around.
Now look
Jerry Seinfeld over here.
Now look who's being inappropriate. All right, well, we have a great episode for you this week. An interesting case of the week. It's a dentist who actually took an impression that's started off well, but it was a two-part impression instead of the kind of the one-phase simultaneous impression that I've become a fan of over the last 12 years, and it led to some unintended consequences. In fact, let's go ahead and take a look at that impression now. I was walking through the fixed department the other day, and I saw something kind of fascinating, and it's a good little story about CAD-CAM dentistry. In the CAD-CAM era, we've gotten used to things fitting pretty accurately, and when you look at a model like this, you can see we have a crown here, and when the articulated model comes together, it's way open. So we've got a crown here that looks to be, I don't know what, a millimeter, millimeter and a half, 2 millimeters too tall. And in the CAD-CAM world, that might as well be 2 miles too high. And you say, what the heck happened here? And so it started an investigation for us, looking back, trying to figure out how in the world did this crown get to be so high in occlusion that uncovered some really interesting facts and things that can happen. So let me, to help establish this story, tell you a little bit about what we do here at the laboratory when a case comes in. So when you send an impression in, a polyvinyl siloxane impression like this, we pour it up. The first pour is always the pinned model. This is going to be the master model, and this is the one that traditionally has always been used to fabricate restorations. We can see the occlusion's good here when we don't have the crown in place, and we bring the upper and lower model together. And then after that, there is another pour made, and it's the solid model. And the solid model has been traditionally used for contacts. And so because of the fact that we've got, these pinned portions of these models, and we've cut out the die for the master die to fabricate the crown on. In the old days, it was with a waxed pattern or a printed pattern as time went on. And we have removable adjacent teeth if we need them. We've always known that this isn't the most accurate model for contacts, and so the solid model was used for the contacts after it was fabricated here. Well, in today's CAD-CAM era, things go a little bit differently. And what happens today is the solid model gets scanned. So after we pour these 2 stone models, we have scanners, kind of like an intraoral scanner, except we're just scanning a stone model. And so what we do is we scan the solid model because we know that this is the one that has the good contacts on it. We want to make sure we give you the best contacts that we can. And then we scan the master die from the pinned model, and we scan this for the margins. And so then we merge the two of these together, or the computer software merges this die with the nice trimming and the marked margin into this model with the good contacts, and that's how the design software allows us to design a crown that's going to fit with good contacts and also fit the margins at the same time. And then once that crown has been milled, then it goes back into the articulated model to work on the occlusion, and it usually needs very little work, and this one happens to be off by about, 1.5, 2 millimeters, and that's where this whole case got very interesting in trying to figure out exactly what happened here. And as we took some steps back, we were able to figure out what happened. It all kind of comes back to the impression. So we'll get to that in just a second. But again, this is the model that's always poured first. You'll notice you'll see some green material over here, some of the impression material that's in there when that get poured. And then here's the second pour, the solid model after that. If we look at the impression itself, you probably can tell as you look at it that this was a two-step impression. And it was a two-step impression, and that it refers to the fact that the purple material was placed into the tray first, and the patient bit down and it set, and then it was relined after the prep was done and the cord was pulled with the green material. And so we have two materials that don't set at the same time, and so they never adhere really well. And as it turns out, there was green material that coated the inside all. You can see a little remnant of it right there. And the rest of it is actually in and around on this model. You can see portions of it that are there around that stone model. And so it kind of got sucked into there, and it pulled the green material out that was on the inside of on the occlusal surface of the impression, here and here, and also on the buccal and lingual surfaces. And then it just kind of tore right off of there as it came off. In fact, as you look at this impression, you can always tell that when it hasn't been done in one step, you just know that this is going to be able to pull right out of there. And you can see just how easily that comes out of there, the portion with the prep on it, because the two of them set at different times. And so there's no way for these two polyvinyl materials, and they're both from the same manufacturer, but they just don't adhere to each other. You know, it's not like adding composite to composite when we're doing an anterior restoration and we have that oxygen inhibited zone and we can bond them together. And that's why I love that simultaneous method. So I'm going to squirt my syringe material around the prep while my assistant puts the tray material in, and then both of those are going to seat simultaneously. And when you do that, there's no way that you can get this inner material out of here. You can never go in afterwards and kind of flip it out like that. It just doesn't happen because they set at the same time, and it's integral. It's one unit. In fact, you've just got green and purple right next to each other with no separation. So when this one was poured, this initial pinned master model, there was green material all along here. It tore out of this because of the fact that it was very weakly bonded to the inside of this purple material. So when the model department poured the second model, when they poured this one, now there was no longer any of that green material in here. And so what happened was, on this model, the teeth, the adjacent teeth to the prep, grew occlusally by the exact amount of the thickness of the impression material that was here. So these teeth on this model, the solid model, grew occlusally, and they grew buccolingually as well. Now, as I mentioned, in the old days, we used to do things a little differently, but in today's CAD/CAM world, we take this model, because it's got the more accurate contacts on it, and we merge this die, this master die, with this model. So this crown was made on this model where the teeth are too big. It's grown occlusally by the thickness of impression material that we missed, and it's also grown buccolingually, so it's wider. And so if we take this and look at the crown on this model, we go, yeah, that's not bad. That fits like it should. In fact, if we look at the occlusion, we go, oh, okay, occlusion's fine if you hold it on this model, because the computer thinks that what the patient has in their mouth matches this model. But we know this model, we know the adjacent teeth in this quadrant are too tall and too wide because it was poured without that inner layer of impression material. And that's why when the crown got to this point and it was ready for the technician to work on the occlusal surfaces, that crown was put back onto this model where the contacts are a little tight, and more importantly, the occlusion is now very high. In fact, we're only hitting on that one tooth. Because that crown was fabricated, by the computer, it was designed to match the occlusal surfaces and the marginal ridges of these two teeth, which are taller occlusally than they should be, because when this was poured in the plaster department, that green material that used to be in here is no longer in there anymore. And so it all started with this impression, the fact that it was a two-step impression and some of the impression material tore out of there, and the fact that we scan both of these and merge it to make the crown. We end up with two models that are not identical. And we know for a fact that the one that's most identical to the patient's mouth is this one. So if this crown had got sent out somehow, if it would have slipped through QC, that crown would have been way high, and the doctor would have said, "What are you guys doing? This was like 2 millimeters too high." And we would have said, "What the heck happened? What is actually going on here?" And it actually all comes back to the impression. So this is just one more compelling reason to do these impressions as a one-step impression. So at the same time that you're squirting the syringe material around the prep, your assistant's filling the tray, you put in at the same time, patient bites together, 3.5, 4 minutes later, you have a very homogeneous impression where you have two colors. You have the purple and the green, but there's no separating layer between the two. There's nothing that can tear out of there, giving you this kind of double impression so that when it's poured twice, you end up with two models of different sizes, and you end up with a crown that's not going to fit. So fortunately, in a case like this, it was caught early enough where now actually these can be rescanned and a new restoration made to fit this model. Now that we know this model is actually too tall occlusally and too wide buccolingually. But again, this is just one more compelling reason. Well, hopefully I can convince you that rather than doing a two-step impression technique, you'll consider a one-step impression. This just in. If you remember the case of the week, or as we call it, the cow, from 2 weeks ago, I'd like to give you a little update. That was the case where Dr. Lee had sent us a picture of a patient who had those 6 veneers on the anterior teeth, and he was going to place some bicuspid. I'll throw the before picture up in case you don't remember that on our telestrator.
Ooh.
Oh, God, I'm sorry. I'm sorry. I'm really sorry about that, Megan. I'm not trying to censor you. This is all new to me. Hold on. There we go. That looks a little bit better. So you can see that it got the 6 veneers on the front teeth. The one on the central on tooth number 8 doesn't look that great, but the patient wasn't willing to commit to having it all redone at this time. And so Dr. Lee's creative solution was, let's fix the buccal corridor and make these teeth look less prominent by putting Emax veneers on the bicuspids and see how that looks. And he sent me an after picture, so let me put that up for you. And you can see now in the retracted photo where we see the smile that it all blends. And that's kind of the magic of that buccal corridor. So I really think that Dr. Lee did the patient a favor. Certainly saved him a lot of money in the short term and gave him a smile he was happy with, but he did remark to Dr. Lee when he was finished that he did want to replace those anterior ones when he could afford it. So a very creative and a very conservative way to deal with a patient who didn't quite have the money to jump into 10 veneers right now, but by adding 4 more to the ones that were already there, solved a big problem of those anterior teeth looking too bulky and too prominent because of the lack of filling on that buccal corridor. But you can see how nice it looks now. So thank you, Dr. Lee, for sharing that. And anybody else who wants to send in a case like that we can take a look at and kind of disseminate a tip like that to help other dentists, we'd love to have it as well.
Thank you for that, Dr. D. Now let's go to a segment we call Viewer Mail. Our first viewer mail comes to us from a longtime viewer and friend of Chairside Live, Dr. Kenneth Wienen from Independence, Missouri, and he writes, "Hello, Dr. DeTola and Megan." Hello.
Hey, K-Dub.
I have a question for Dr. DeTola in regard to Bruxer crowns. This has to do with the occlusal clearance. I know the advertised clearance is 1 millimeter. However, when I send in impressions and there isn't much room, the lab says they need 1.5 to 2 millimeters. Can you clear this up for us? Thank you in advance. Best regards.
Wow, well, this brings me a great question, K-Dub, and this brings me to a very impromptu segment that we like to call
Oopsies!
Yeah, we did not get this one right. And unfortunately, mistakes like this on the telephone happen, and I'd be willing to bet you or Dr. Wienen a tub of cream cheese that this kind of thing might happen again even though we don't want it to. And so actually, the advertised occlusal clearance that we really want for Bruxer is 0.6 millimeters. And the reason it's 0.6 is because our break tests seem to indicate that's about where, once we got to that point, it would break way too easily and fall down from that 1,000 megapascals of flexural strength that we often talk about. And also because on my burr kit, that reverse prep burr kit, I've got a 0.6 millimeter depth cutter that I used to use on the anterior teeth on the facial for veneer reduction. But I now use that 0.6 millimeter depth cutter anytime I'm doing a Bruxer restoration on, for example, a lower second molar. And like you said, there's not a lot of room to reduce. I know that if I put those holes on the occlusal surface with that 0.6 millimeter depth cutter and then I prep till I can't see them anymore, it's probably going to end up being 0.7 or 0.8 by the time I'm done reducing all that and getting rid of those holes. And so I'm going to be within that safe zone. 1 millimeter, as you mentioned, is great too. There's nothing wrong with that. But to call us here at the lab and have somebody tell you that it needs to be 1.5 to 2 millimeters, that's just simply not true, and that's inaccurate. I don't think anybody was lying for any nefarious reason. I just think maybe in their mind they confused for a minute Bruxer occlusal reduction with Emax occlusal reduction. Emax we would definitely want, and Ivoclar Vivident definitely wants 1.5 to 2 millimeters of occlusal reduction. So maybe it was just one of those things where something happened when they were on the phone and they got the two products mixed up, and that's why they told you that. But certainly 1 millimeter is plenty for Bruxer, and like I said, 0.6 millimeter is actually the absolute minimum that we can go to. Keep in mind though, Ken, if you reduce a millimeter on, let's say a lower second molar for a Bruxer crown, and you get it back and the patient's temporary had fallen out a couple days earlier and you have to do some occlusal adjustments, now all of a sudden you might go down from a millimeter thickness on the zirconia down to 0.6, and all of a sudden it could weaken that restoration to the point where it might break. So anytime you're doing one of those minimum thickness Bruxer crowns, if I've got a problem with occlusal reduction when I try the crown in and they're not coming together all the way, I'm pretty much always going to adjust that opposing tooth instead of the Bruxer restoration. But good question, and oops, sorry we gave you that erroneous information, and I hope that straightens that out.
Our next letter comes to us from Brent Peterson, who writes, I'm in dental sales. I really enjoy the show and the humor. Oh, you must be talking to me. Thanks so much. Few things make me laugh out loud like your comments do. Oh, dang it. I guess he's talking to you. Whatever. You're funny. Really great. I watch it while I exercise on the treadmill. On one episode, you gave some stats on the frequency of requested tooth shades from doctors, A2 being 27% of the requests the lab gets. I have a different question on frequency. When you look at all the single full coverage crown requests the lab gets, do you have any stats by tooth number of what gets requested? Thank you for addressing my geeky question.
That is geeky, Brent, but I like it. It's geeky kind of like the same way that I get slightly aroused when I see a burr wallet. I don't know if you know what a burr wallet is, but the rep will come in and you'll open this wallet. It's got hundreds of different burr shapes in it for grinding on teeth, and most people would look at it nothing, but I look at it, it's like, whew, I start looking and get excited. And that's pretty geeky too, Brent. So way to geek out on the treadmill. I can hear your feet pounding now as you watch this episode. Let me also say there's a special place in heaven for you for choosing to be a dental sales professional for the rest of your life. We're not the easiest people to sell to. In fact, we can be downright cheap at times, so thank you for your patience. And that is a great question about the distribution of crowns that actually get prescribed for the different teeth. And to answer that, let's take a look at it on the Chairside Live Telestrator. So Brent, let's answer your question by taking a look at the numbers themselves. Let me go ahead and put them up there. Oh, how sweet is that? That's not it. Oh, that's horrible. Where did that come from? What could be uglier than that? Me, fat and huge? Ooh, well, that answers that question. Jeez. There we go. That's what we were looking for. We got some numbers here. And as you might expect, Brent, the teeth that are most often to be missing, either because they've been extracted normally or they've had a root canal or a crown done, are the first molars, especially the lower first molars. So as you can see, when we look at for example, number 19 and number 30, you can see those are, in fact, the most restored teeth here in the laboratory. And then right after that, we've got the two upper molars, tooth number 3 and tooth number 14, which you would probably expect as well. We've got some outliers. Look at teeth 1 and 16. Very few crowns being done on those. In fact, that's got to be somebody who's just got a perfect occlusion where those are actually have room, they're erupted properly, and they're actually in occlusion. I guess you would consider doing crowns on those kind of teeth. Look at 8 and 9, a little higher than you might expect. Of course, those are going to be the ones that are most often injured because they're right in the front and are most related with appearance, so they're going to be restored. And of course, as you get to the lower anterior teeth, 22 through 27, my least favorite teeth to prep, and you can see those do not come in very often for crowns. They also come in for veneers, but it's pretty insignificant as well. Those teeth rarely get worked on. And the second molars, as you would expect, have a tendency to fracture as well, either because of a large amalgam, but they also do a lot of chewing back there, a lot of force in the back of that wedge shape bite. So as you might expect, the molars get restored the most. And the bicuspids, 4 and 5, see more action than the lower bicuspids do. And so I think that's about as close of a look as this geeky type of chart as you would have wanted. The numbers pretty much back up what we've seen in our experience. If you talk to most dentists, they will tell you that roughly, yes, they do more crowns on lower molars and then upper molars than on the rest of the teeth. So I think these statistics bear that out, and it kind of follows along with our common sense personal experience. Thanks, Brent. If you have any more geeky questions, feel free to send them in, and I know we've got enough numbers to back up any question you might have. Well, that was 2 letters. Do you have one selected for our Chairside Live letter of the week?
I do, actually. Dr. Weenan, he's been here before.
Right.
I'm sure he already has plenty of our pictures hanging on his wall. And actually, we could even maybe show a picture of him and I when he came to visit the set. So I think that we're going to have to go with Brent.
Okay.
But you would think that it's going to be a photo of you and me. Which,
I would think that.
I mean, of course, we have it. This is you and I just being super Western.
Well, this is the first I've seen of this.
You're welcome.
Who's responsible for the Brokeback Mountain Chairside Live shot? Who did this? Who's the guy in the cowboy? Who's the guy in the horse? What's he doing? Is he a dentist?
Who's the guy on the cowboy? That's
no, who's the guy? That was Brokeback Mountain. Yeah,
right.
No, I'm asking who's the guy on the horse. That's what I meant to say.
It looks a little bit like MacGyver. I'm not sure.
That's awesome. I remember that trip to the Grand Canyon you and I took. It was fantastic. Remember when we dressed all formal?
Yeah.
Oh, it's not the Grand Canyon?
No, I think that's somewhere like
Utah?
Red Rock or
Southern Utah?
Yeah.
Monument Valley.
Monument
Valley.
Valley.
It's Monument Valley.
But okay, so enough talk about this wonderful picture, which you will receive to hang up by your treadmill. But
Awesome.
I think that it's time for a new prize.
I would agree. It's time.
Dun dun dun.
Oh, look how you did that.
That's right.
Look how you
Oops, I did
foreshadowed
it.
what the new prize was by saying time with such an emphasis on it.
Right, so Brent, you can forget the watch at home or the Garmin. You don't need it. All you have to do is just put this up there.
All you have to do is tell time on a clock with no numbers on it.
Perfect. And you've got the motivation of hearing your fitness story and seeing you there all fit. It's perfect.
I'm going to go on record and say my kids, they've all grown up with like digital watches, digital clocks. Nobody wears watches. They check their time on their iPhone. I bet my kids could not tell time on this clock. That would be a fun segment one day to bring my kids in and just show it to them and see if they just sat there with dumb looks on their faces or if they actually knew what it all meant.
Well, yeah, bring any kid in here that was born in, 95 and up.
I meant particularly my dumb kids. I have really dumb kids. That's why I said that. But you're right. It could possibly work with any kids.
But basically,
they don't watch. Trust me. Trust me. I tried to force them. I thought maybe having you on there would. Oh, hey, who's that? Look, somebody young. It's not just old you, Dad. But no interest whatsoever.
Well, my parents watch it.
That's true.
But I mean, and they hi, Mom and Dad. They love it. But my brother, not so much.
That love kind of goes one way. It goes
my sisters-in-law.
Parent to child, not not child back to parent. And it's funny you mentioned the pictures because we had Dr. Marshall Horowitz was the letter of the week once, you might recall, a couple months ago. And we sent him a picture of us, and he actually sent back a picture of himself to us.
Oh, yes.
And look, there's a little photoshopping going on here. I'm really impressed, Dr. Horowitz.
I'm proud of that.
I'm proud of you to name yourself the sexiest man alive. That's pretty awesome. He did 2 takes on it. There was one looking a little like, as you pointed out, Ed Helms in The Hangover, missing that front tooth. And then another one, this is how every woman, this is why for us as dentists we have so many groupies. I don't know if you noticed, but a lot of times when I leave, I know I leave an hour after you do in the afternoon, there'll be 10, 20, 30 women waiting for me as I walk out.
Women? Is that anything like women?
Yeah, they're usually just looking for, it's a more PC way to say it.
Okay.
They're looking for autographs, a picture with me. And this is why. When you walk outside with loops and extraction forceps in your hand, it might as well be a guitar. He might as well be a lead singer in a rock band with a guitar.
Forget the milkshake, bringing them all to the yard. You just need those
loops.
loops.
That same kind of animal magnetism when you see that. So, Marshall, thank you very much for bringing up just how sexy we are. All right, you have any news for us?
I do. A new study reveals that periodontal disease can significantly impact a person's overall quality of life. Swedish researchers performed a clinical and radiographic exam on 443 individuals. The result? The disease substantially affects the quality of life. Those with the disease experience functional limitation, psychological discomfort, and social disability. Many had difficulty pronouncing words. Even tasting and eating food wasn't easy. Maybe worse are the social and relational impairments the disease can cause. Feeling insecure, tense, embarrassed, and irritated, often finding it difficult to just relax and do normal daily activities.
And I read part of that study, and they did have trouble pronouncing certain words, like Swedish researchers. A lot of them couldn't even say that. That was difficult enough because
it's a hard thing to say.
It is. It's a tricky phrase. Something you'd see at IKEA on a sign by the Swedish meatballs.
That's exactly what I thought of when
and
I
the lingonberries
and
and all that stuff. They have that 99-cent
IKEA.
breakfast. I'm dying to try, by the way. Doesn't that seem wrong? How can you serve breakfast for 99 cents?
I don't know. And if there's meat involved, it's even more scary.
And is it assembled, or do they give you tiny little things where you have to assemble the breakfast itself with that tiny little wrench?
Does this come with instructions?
You know, it's funny. I get upgraded a lot on United Airlines because I fly a lot for lecturing, and so they just do it for free. Oh, it is. You can only imagine what happens on the other side of that curtain. By the way, Virgin America, you know that curtain they used to slide between first class? They stop a lot. Air Canada does it, but most U.S. airlines don't do it for security reasons.
Right.
Virgin America has a red rope, like at a club.
It does.
It's pretty awesome between the first class and that.
VIP.
It does look like you're sitting in a section with bottle service in the VIP area. But I do get upgraded for free, and because I have 1 million miles on United, and I've noticed that when you sit there, more so than in coach, there's a lot of periodontal disease in first class. And you'll be sitting next to somebody, it's typically a man. Okay, it's always a man.
I was going to say.
It's always a man who's like, the CEO or the CFO, and you start talking to him, and the breath just hits you like a frying pan in the face. I mean, it's just like, whoosh. And the first thing I always do is look down, and I'll swear 2/3 of them have a wedding ring on. And I'm like, wow, how does his wife, put up with this? So I know that in a certain sense, they're able to function, the people with severe periodontal disease. But I also think that a lot of these people, a lot of these guys developed it after they were married. So maybe they got married when they were 30 and they didn't develop this periodontal disease until they were, say, in their 40s or 50s, and that's when the breath thing started. And the woman's just such a good-hearted person that she stays anyway. Because when you see the younger people with periodontal disease, it is almost literally debilitating. Their ability to eat, to chew, to speak, you'll see the hand going up to cover the mouth, and I think it's pretty awful. I've always wanted the American Dental Association to run one TV advertisement per year.
I've heard you say
during the Super Bowl, just for periodontal disease, and just say, you know what, when you brush your teeth and you spit, it shouldn't be red. If there's bleeding going on and you spit in the sink, it should not be red. It is the one thing that seems like we could really control if people were just educated a little bit better about what's waiting for them down the road, especially once we're able to identify the people who are definitely at risk for this type of disease.
Yeah, and I think that commercial might be effective, especially if they used the tactic that I believe it's the Lung Cancer Association or whoever puts those ads on of just those super graphic images of the people with who had the tracheotomy because of lung cancer or whatever. If they showed like a horrible case of periodontal disease or talked about what could happen, I think that actually might be effective.
Yeah, like when you see the person smoking through the trach hole.
That's what I'm talking about.
It's stunning, and that's when I quit smoking in dental school, is when we dissected our cadavers and you saw what emphysema looked like. And I always felt like if you could wheel that cadaver into every 6th grade class, kids would never start smoking. But people go, oh, no, you'll freak them out. And it's like, it's just reality.
Right.
Okay, granted, they've never seen a dead body before, so maybe you start with the class bully and make him go over and reach like barehanded into a body cavity, teach him a lesson.
I don't know about that.
But otherwise, if you just show people the reality, because we're putting warnings on cigarette boxes instead of actually showing what happens. In Canada, you should see some of the nasty pictures that you'll see on cigarettes and on billboards. It's really, to your point, it's really kind of stunning. And I'm sure there's people who see it and get used to it and go, I'm going to smoke anyway, but what are you going to do? Anything else?
Yes. Excuse my potty mouth, but it looks like your urine is good for more than just proving to your employer that you're clean. It can also be used to make teeth. Researchers recently converted cells from a urine sample into cells that can be grown into different types of tissues and grew teeth. This could represent a non-invasive way of getting stem cells from children. But don't run to the bathroom just yet. Turns out urine isn't the only route to take. The cells necessary for the process of generating new tissue can also be found in a single strand of hair. What are you doing?
I'm sorry, I was just making some teeth.
No!
I heard you read the story.
Okay, and at the end, did you hear the part that it can also be made from a strand of hair? We don't need you.
Hello? Hello? Follicularly impaired.
You can borrow one of mine.
Wow.
Sorry.
I think I deserve a handicap placard for parking now because of my disability. Well, by the time you got to that, it was half full.
Okay.
The glass was half full by the time you got to that part of the story. So I made you some teeth, and this is the thanks I get.
You know, and I'm saying how absolutely vulgar and disgusting that is, and it is, but they were saying that, you know, as most people know, that midstream urine is completely sterile.
Right.
So I guess it's not like that gross, but...
Right. Little known fact, my entire stream is sterile. It's not just midstream. Seriously, first drop to last, clean as a whistle.
Do you see what I have to deal with? This is my life right now.
You can eat dinner off it.
Oh, God. Help
I know
me.
you're midstream, but I'm 100% effort. 110%. That's how much I care. So what are they going to do with this? Start building teeth?
I mean, I guess. But that's what they're saying, that it's awesome to know that, because the other way that they had to extract stem cells from children was invasive, and they had to go in, which obviously no kid would want to do, but so to just pee in a cup is so much easier.
Right.
So, I mean, I guess the focus is then on just the way of how they can make these cells instead of, you know, trying to make teeth. But it is pretty cool that they were able to do it.
I feel like if they could harness this and by, say, peeing on a campfire would create a pile of teeth that tooth shortage over. Just from camping, men alone. I don't know if you've camped with men before. One of the great joys in life as a man to pee on a campfire. And I got to go make some teeth. Maybe that'll become the new expression
maybe
as time goes on. You know, there's a new genetic testing service that a friend of mine just did. If you go to 23andme.com, they did not pay for this advertisement. 23andme, and it takes about a half hour. You fill up something full of saliva and you send it in, and they can tell you all these things about your background. And it was actually this friend I know, and I was like, you know, how do you know that what they told you? This sounds like a psychic. And he started telling me all the things they told him about his eye color, his hair color, the fact that he would never be a runner, never be able to run. He's like, I absolutely can't run. That he's got male pattern baldness, and he's not like me, but he's getting there. And they just thing after thing after thing about the different tastes, what he's able to taste more than other things, and it just blew me away as he started saying these things that they had never met him, never seen a picture, and they got all this. He found out that he's resistant to AIDS. He's resistant to HIV, for one thing. But there was something else that he was
I don't know if I trust that.
that he was not resistant to. And I don't remember what it was, but I'm sure he does. He's probably living in fear. But anyway, this thing called 23andMe, that same kind of thing, where just from saliva they can tell all this stuff about you. Might be a fun little Chairside Live.
I was going to say we should do
for
a
you and I to do
expose
that. That would be fun.
and reveal some of. Oh,
that's not water. I just
nope,
remembered.
That was
I got some
your waist.
teeth on my teeth. Good thing it's sterile.
Wonderful.
So we'll do that. We'll spit into a cup and send it in. See what it tells about us. We will do that. We'll do the spitting live into the cup on the show.
Absolutely. Would have it no other way.
Well, I talk, you'll do it, and while you're talking, I'll be over here. Looks like we're
We'll work out the
got some
logistics
Copenhagen
later.
in our mouth, spitting into a little cup.
Okay.
All right, that'll be fascinating. We'll do that. That about wraps it up for this edition of Chairside Live. On behalf of myself, Megan, the Chairside Live crew, and everybody here at the laboratory, I want to thank you for your time and your continued commitment to quality dentistry.
Y'all come back now, you hear?
What'd you say?
Oh, Peter owes me a tub of cream cheese.
Oh my God.
So don't reference the telestrator and don't do the throw now because the telestrator's not coming to
Are you kidding me? Did you hear that?
Plaster it on her face.
Right.
But the other thing we should still
She
stand
needs to
out,
hold
though.
still.
This is it. I'm just going to superimpose it on her head.
No, I know. Okay.
Oh my gosh, you're
body's
missing this
moving,
whole
you can't
thing.
No, I can
Oh
figure out a little
gosh.
bit with it.
Okay.
That is funny. And then Andrew goes, yeah. Peter owes me a tub of cream cheese.
Wow. That sounds like one of those Super Bowl bets with the mayor of Buffalo, New York, where he'll bet like the mayor of Miami, and it's like, well, you owe me a tub of cream
Why
cheese.
is that so funny?
It's
Yeah,
just the
throw
most
that up.
random thing you could ever say.
Right.
He owes me a tub of cream cheese. Or I could just look into the camera
It was the funniest thing
and
you've
say,
ever said.
congratulations, Dr. Lee, on a great case. and then she could go, okay, thank you, Dr. D. Now it's time for a segment we call Viewer Mail.
You hear that, Megan?
Sorry, all I got was, and then after he's done, I say viewer mail.
Yeah, we're just going to do it live. You just do your thing.